Hey, Ed, really excited to have you on the show because you are tackling such an important problem, which is a global healthcare access gap across low and middle income countries. So could you share a little bit about yourself, Ed?
Oh, yeah. Hi, everyone. Thank you for having me, Jeremy. I'm Edward Booty. Yeah, I'm founder and CEO of a social enterprise called Reach 52. We focus on healthcare access, which means access to medicines and health services in emerging markets across Asia and more recently Africa as well.
I know you're doing such an important problem, which is providing healthcare services to billions of people across the world. But how did you get started? Did you know what you were going to do back in London School of Economics as undergrad?
Yeah, so I'm from the UK, as you can probably hear. Been over in Singapore for about 8 years building this company. Yeah, when I left university, traveled around India, actually. I decided to not work straight away. Went to most northeast, southwest of India, saw a lot of people without basic healthcare access, found that a bit of a shock. Volunteered at some NGOs, but I didn't really like it. It felt not businessy or on the periphery of like mainstream society, if you will, like little side charity project, something like this. So I saw a lot of health access issues, got a bit of a shock in India, didn't really, the NGO sector didn't really feel it was going to move the needle. Ended up with an internship in a big pharma company who was trying to sell affordable medicines in rural areas. They were willing to lower their margins. They were willing to actually try and access these harder to reach markets, but it's just so hard. Small distributors, small suppliers, they can't get comfortable with credit risk, potentially getting paid, compliance, quality. There's limited demand for products. So, you have this big global multinational company willing to try and help and just facing way more obstacles than if they just did normal commercial work, such as selling to big pharmacies, big hospitals and cities and so on. So yeah, I saw that firsthand when I was 21, had the idea for Reach 52 when I was 21. The idea was to just build a platform whereby we can be a credible partner to give access to affordable medicines and also build demand for those medicines. Because often just having a nutritional on the shelf or a diabetes product on the shelf of a pharmacy doesn't mean it gets used unless you know your kid is malnourished or you have diabetes. So you need to do education, screening, access to doctors, which of course builds product category demand as well. So yeah, saw that firsthand, didn't have any money. I've still got the original pitch deck from Reach 52, the original 2-pager, which I actually looked at recently for different reasons, but fascinating to see it because it was just an idea I had when I was 21 and put some slides together for. I then worked in consulting, saving up money the whole time, building the website on the weekends, set up the email, started pitching people for the concept. And yeah, eventually had enough traction that I left my job, one-way flight to Singapore, set up the company. Not quite what we planned in terms of the first version of the model, if you will. But yeah, rest is history.
So what's the difference between the first version of your model versus, what
Mhm.
Reach 52 is today?
Many things. Yeah, so obviously health tech, innovative models are, relatively mainstream within the VC or just broader health innovation space, right? We're trying to move people away from, not always, but partly trying to move people away from hospitals and so on and go online and e-pharmacies and so on. So I guess the first version of the model was a very tech heavy model where instead of like telehealth, you can use your phone to speak to a doctor. You could potentially order a medicine if you live in Singapore or a city. Our idea was that you'd have a kiosk and a shared telehealth model, if you will, where health doesn't reach everywhere, but schools, shops, places of worship do, churches or temples or whatever. So the idea was we have a 10-inch tablet. You could speak to a doctor for free, sponsored by companies. So companies and partners would pay for that infrastructure. And you could also order a discounted medicine that would be delivered back to that community facility. Didn't really work. Regulation gets in the way. Even if it's free, people still want to go and be touched by a doctor and walk out with something to feel like they were listened to. So we thought people might overcome that. If it was free, if it was localized, people might shift to a digital first model. But yeah, 2 years later, they didn't. So we sort of pivoted the tech. It's now used predominantly by health workers. So it's more of a not direct to consumer tech platform. We took the tech. It's now used by health workers. They collect data on their community's health needs. And then based on understanding which household has an unvaccinated person, which household has a person with a malnourished kid, which person is at risk of diabetes, which household has a person at risk of diabetes, we can re-engage specific households with specific health interventions. So it became more of a sort of B to health worker to C engagement models. The other big change from the original was that if you want to work in emerging markets, if you want to really go to more rural, underserved communities, you can't just be a pure play tech platform. It's distribution. You have to get medicines on shelves. You need boots on the ground. We're trying to be asset light or fast tech growth mindset, but tech orientated engagement didn't work. B, you really have to also work on the supply chain and face to face and getting the products to the communities and working with these distributors that are paper based, not innovative, not really willing to use a tech platform type organizations to really drive that education and demand and make sure affordable products are available at local levels.
And when you say that you're training kind of local community members, how do you go about choosing them? Because is it somebody who raises their hand? Is it somebody they're scouting out for? How do you go about that process?
Yes. Yeah. Also changed over the years. We are in 7 and growing countries as well. So it varies a little bit by market. But sometimes there's a government cadre of community health workers. Fun fact for the podcast, 85% of community health workers are actually unpaid. So if you go to Africa, Philippines, these sorts of markets, you have community health workers at village level that are paid from $0 to a $10 travel allowance per month. They do have some basic training from government. So you have this sort of cadre of volunteer health workers that wrap around or support the government health center, primary health center. So sometimes it's them. Sometimes we work with NGOs. Sometimes we put up posters and flyers and do local recruitment. But generally, we try and work within the government system. The government often has these cadre of unpaid health workers or low pay health workers that we can upskill and empower. But in other markets like India, we're doing more with NGO workers, and there's like self-help groups, which is other community structures around women's empowerment groups that might do like microfinance, microcredit, this kind of stuff. We work with those groups as well. But generally speaking, it's working with an existing trusted network of people that we look to upskill and empower to support the health promotion side of our work.
So when you think about this kind of like recruitment process, so how do you think about the different layers from your perspective? Obviously, you said there's a digital layer and a HQ layer, and then there's the health access worker. So can you share an example of how something flows from the top or the hub to the patient or the person getting the beneficiary at the end?
So we obviously have our headquarters here in Singapore. We have teams in the Philippines, India, Indonesia, Kenya, and so on. So project managers, if you will. We don't call them that, but effectively the role as a project manager, we'd be working on, say, a diabetes screening program or a nutrition screening program. We'd develop the content, training, education materials for both the residents themselves, public health content, as well as the health workers, sometimes the doctors, because if the health workers are referring people to the health center, often the primary health doctors, nurses wouldn't necessarily have been trained in that topic. So you have to think about the training or public health engagement content with those 2 or 3 lenses. We'd develop that generally centrally, sometimes with medical consultants or local medical experts. So it's locally tailored, relevant, say, do the training. We'd generally facilitate it. Sometimes we have local training partners as well, depending on the country. And then, once the health workers are trained, they've often collected that data up front already. So when we actually start, before we have any funded programs or any sort of public health engagements, the health workers are normally trained on the app first. So that's completely separate. They would survey their communities completely separately. We fund that as Reach 52 as part of our thing. And then, you've got the app in the health workers' hands. You've collected that initial data. You retrain all relevant stakeholders in that specific campaign topic. And then based on that, through the app, the health workers would get specific households to engage with that health intervention. So if people at risk of diabetes are in house 1, 20, 50, 100, they would generally just go to those households and in this case do diabetes education and screening. And if their blood glucose is high, refer to the primary health center. And in the next month, the next quarter, depending on how many people they have to engage, could be engaged in a house to 20, 50 with malnutrition content. So it's more like a sort of iterative cycle of retraining and re-engaging based on the upfront data collected.
So how do you think through the dimensions between the partner versus the beneficiary, right? So for example, like diabetes, like who are the stakeholders you work with? Obviously in local government, village councils. Of course, there's also other funders and partners and stakeholders you're working with. So could you share, using that same example?
So I guess there's two, so taking a step back, there's two ways we fund campaigns. The public health campaigns, one is we have a B2B sponsor and sometimes a donor to UN agencies, Pfizer, J&J, Bayer, Sanofi, all great partners. There's a funder for the program. But we also distribute medicines, as I mentioned, the part of the model that I mentioned right up front. And we're often making a margin on the products that we distribute. And we often use some of that margin to fund our own public health campaigns as well. So sometimes it's internally funded through Reach 52 distribution margins. Sometimes there's that external funder. For our own distribution side, we have a calendar of public health events. Sorry, our own distribution margin funded side. We have a calendar of health events that we do. For example, if it was like rainy season, respiratory illness might be high. We'd do health events and engagement around respiratory illness and kind of things. There'd be a calendar at local level, agreed with local stakeholders. We just do it on our own. And that's about it. We have margins. We run health events. We do those engagements. And that's it. No other stakeholders really, I'd say. For the ones that are partner funded, yeah, interesting dynamic. I guess we've not often, maybe 2 or 3 times, been called honest broker in all of this. So often we're the sort of integrator. All we care about is Reach 52. 52% of the world can't access essential healthcare. It's our mission. It's our purpose. It's the name of the company. All we want to do is get affordable essential healthcare to rural areas. So yeah, often there is a pharma company funding it. We don't promote products generally. We don't push products. This kind of thing is core funding, if you will, or we're just funding to promote the core health disease area. And yeah, government commissions, if there's an implementing partner that's helping us do the training, train them up. If there's a funder behind it, agree the scope of work. And then with the facilitator and integrator to get local permission, let's get funding facilitated for train the trainer on the actual training. Then yeah, that's kind of it. And there's sometimes peripheral partners as well. We've had academic partners doing evidence generation about our model. So sometimes there might be a sort of academic research partner that wants to publish a paper about the impact of what we do. Yeah, sometimes we might have to procure diagnostic tests. Yes, if we're doing diabetes screening, we would also be involved in sourcing the blood glucose meters and the test strips, and then you'll be negotiating that to make sure there's diagnostic and screening tools available. So there might be some things like this, but generally, yeah, it's government, local partners, funders, and then sometimes that funder might be removed if we're self-financing.
So there you are. And how do you measure impact from your perspective? Obviously, it's going to be a number of beneficiaries. Impact measurement is such a big problem for social enterprises, and you're doing this across the global distribution, across different programs.
You could get me in a negative train of thought or a negative conversation with this. So absolutely, I do struggle with impact measurement, management and evaluation. As I tell many people in meetings and whatever, rarely online, but we've done 4 diabetes screening programs in the past couple of years, 4 different funders. They have 4 different frameworks. Some people just want photos of happy, smiling beneficiaries to put in their PowerPoint to say, look, we did something nice. So it really is corporate, do good type mindset where the payment is photos. Some of them have an 80-line Excel with way too many indicators for a basic diabetes screening program. Some people in PowerPoint. So all of a sudden we're in the middle doing diabetes screening programs that sort of perpetually fragmented because different funders measure things in different ways and want different things on different timescales. Startups should want to get to scale. And it's like I always say with fintechs, you don't see banks debating what a dollar is. Whereas in social impact, you have to debate what impact is and therefore, or what the specific impact is. And that means you don't really get big scaled solutions because different funders have different impact that they want to make, that they measure in different ways. And when that trickles down into the people doing it, you don't just have one standardized core service because everyone does the same thing fundamentally, but can pull you in slightly different ways. So that's definitely probably arguably one of the top 3 challenges of Reach 52 is how do we develop a scaled service whilst appreciating measurement of what good is or what impact is varied between our partners. The way that we have done that and what we do measure is lives improved and products distributed. So let's just take the examples I've used already. Nutrition engagement, access to nutrition, that's a life improved. Diabetes screening, access to diabetes medicine, that would be a life improved. And generally we see it as taking people one step beyond on the patient journey, if you will. So if you were at risk of diabetes and you've not been screened, we've improved your life journey if you know your status. If you've already been screened and you can't afford the medicine, if we screen you again, that's not necessarily improving your life. But if we give you access to that affordable medicine, you take them that step forward. And then it applies to everything we do. We've done, and we are doing diabetes screening, vaccine access, nutritional screening. We're doing work around mental health now, 20 plus health areas actually. And yet we're always just trying to move you one step forward on your health access journey. And then sitting beneath that, there would be a bunch of sub metrics depending on the associated partners and what they want to see. But we try and create 2 simple metrics that can sit above the fragmented and diverse reporting that we have to do. Yeah. And everyone has to do in this sector.
So I think switching to the other side, which is what we're talking about the funder and the stakeholder side, right? Which is about who is interested in helping them. And also I think the monetization or business model that you're also working on. So how do you go about being a social enterprise that is looking to obviously generate these health outcomes, generate this impact, while also being sustainable as a business?
Again, yeah, huge question. Yeah, and then like step back, clarity. Yes, we are a business. We are a company. We're not a charity. We're not an NGO. We are absolutely impact orientated. The name of the company, the DNA, is all about just increasing access to health equity, access to medicines, and so on. I personally don't see the difference. I always think sometimes I speak to different funders. I can be a innovative health tech and be authentically telling the truth. We have this cool tech platform. We collect data. We're targeting people. We're distributing medicines. We have a data warehouse open over time. We can do great insights. We can be a tech company. I can also, almost pitch you as a pure commercial investor. We're opening emerging markets. We're accessing an untapped segment of customers. We're bringing old-fashioned distribution as a traditional industry and modernizing it as a commercial pitch. I can also speak to you as an impact investor where, a majority of our people that we engage have often never been screened for a disease. Medicines are often way too expensive. We're bringing down those costs, making it affordable. So the way that I see it is we have our core service, but you have to be smart about, and it's in no way lying, just presenting yourself in a certain way. I am a social enterprise founder. I deeply care about my mission. It drives me more than the money. I'm also absolutely a business guy. We are not a charity. We want to make profit. We want to be sustainable. We have raised VC money, some pure commercial VCs, some strategic institutions, some impact investors, but absolutely want to be a sustainable, profitable business. I deeply care about innovation. I want to, as the aggregate data, I want to AI-enabled forecasting or whatever over time. I want to be tech-forward, business-orientated, and impactful. And one of my personal missions in life is to actually prove that those aren't disconnected. People would often assume you have to be one or the other. I think it's above Reach 52 in terms of my sort of drive and purpose. I really want to prove that you can be deeply impactful, making incredible social impact at scale and making profits, making good profits, not thin profits, but market rate, EBITDA, whatever, 10 and 15%. That's what we're targeting. And I can also get a bit frustrated because you say you want to help poor people access healthcare. All of a sudden, you're bucketed as a charity guy. And if all of a sudden I say I want to build an AI health tech company, all of a sudden I'm like, cool, startup founder, right? If you say you want to make money in healthcare, you're seen as too businessy. I don't get it. You can be great, and we are both genuinely or authentically with folks. So yeah, we have one core service, but you have to be smart at presenting it in different ways to different stakeholders while being true to what you are.
I've been a social entrepreneur myself, and it feels like that was in the vogue, I would say 10 years ago. And now it very much feels, I think the energy for what traditionally would have been like, hey, I want to build something that's impactful is in the startup space, I would say. So how do you think about that kind of to and fro?
You've asked a good set of questions because you've hitting on all the things that like bug me in the sector. So yeah, it does. So firstly, absolutely correct. It does go to and fro. Social business was the buzzword 10 years ago when I was working in the pharma company, right? It was one of the earlier social business programs as pharma companies tried to do access to medicine in different ways. I think you just have to accept it and not be like the emperor's new clothes, like constantly redeveloping yourself. But yeah, if I was harping on the same way that by the sounds of it, you did as well 10 years ago, you wouldn't get the right notes of the current market, investor, business sentiment. For example, now everything in my world is called health equity. Where that word came from, but a year or so ago, access to health, access to medicine, all this kind of stuff that I do. You go to World Health Assembly, the WHO's annual general meeting, United Nations General Assembly, all these kind of like big multilateral global hoo-has of big words meeting. Health equity, the thing now. I don't know what, but now I have to say health equity, which is what. But yeah, you have to just understand that it isn't evolving to terminology, naming, etc. changes and just evolve with the market sentiment and the associated taxonomy. Just constantly present yourself. But I do absolutely reject, even the team is saying it now, like, let's just do AI. Let's call ourselves an AI company and do more with our data to make this an AI. We're rural distribution company that trains health workers and does education and screening. I'm not just going to start putting on the website powered by AI to try and woo more funding, because that is inauthentic and that is not true. That's not what we're doing. So you can't jump too far to try and be everything to everyone always. But you do have to gradually evolve with narratives and how you present yourself, for sure. I do actually say more recently, even being a health tech is not necessarily cool. We've had huge blow-ups in the sector, right? We think about some of the very well-funded $100 million plus, the Babylons, the Bioformuses, these guys coming from Singapore and other markets have not done so well. The most funded health tech company with an innovative, we're going to disrupt the traditional care pathway with AI and virtual doctors, blew up spectacularly, having raised 700 million US dollars. In the big health techs of the idea right now. I think in a way, you have to just be realistic that, yeah, the world has changed quite a bit. Startup funding has changed quite a bit. Social enterprise isn't in action. But actually, a lot of investors and people have got burned by super cool tech innovation, health tech innovation as well. I don't think that's worked. One of traditional business models, for example. So yeah, accept it, roll with it, and just have your eyes on it.
As you think through the future for Reach 52, what are some of the future directions you think? Is it more countries? Is it more beneficiaries? How do you think about that?
So I guess it's all of the above. So yeah, firstly, Reach is a very tough startup to build. I often say to people, anyone that listens, really, there's no point in doing one bit or the other bit. If you distribute, you'd get, hypothetically, if all medicine became free, Right now, all medicine becomes free. You have to give it to distributors, they're going to mark it up. When it gets to the pharmacy, it'll probably be the same price. If it's sitting on the shelf of the pharmacy, all this new, amazing treatment, people don't know they have a disease. What's the point? People aren't just going to wake up in the morning and want to buy diabetes medicine. They don't know they have diabetes, right? That's just fundamentally logic. So you have to think about the pricing, the distribution, managing the retail side, making sure affordable medicines are there. These communities are opaque, they're rural, they're often saying these things. People don't understand how expensive medicine can be in rural areas. I always say it's like you go to a city and a supermarket and you buy a bottle of Coke, it might be $1. When you go to that small mini mart, it might be $1.50. Like when you're in like whatever, rural Indonesia or something, you often pay more for consumer goods if you go to smaller outlets, right? The same for medicines. I go to pharmacies in the Philippines, the chain of pharmacy, right? A chain pharmacy and Medicine X costs $4. You go to the same chain pharmacy in a rural area, it can cost $8. It's double the price. And you're still just going to Watson's or the equivalent chain pharmacy, just in a different geography in the same country. Pricing has to be key. People don't actually know. A lot of health data firms do not operate in rural, don't actually know what medicine people need. So that data collection is absolutely key. Community one, like how we see it, high renal disease, kidney failure. Community two, right next door, might have high malnutrition. Community three might have crazy diabetes levels. So having that data. And then driving health promotion, education, screening, access to doctors, was all parts of that. Absolutely committed to do that. Do maybe drop one, I'll resign as briefly to founder. It's absolutely pointless. Health access won't be a reality. So committing to the enlisted model. And then, yeah, absolutely. More beneficiaries. We engaged 2 million people up until we improved 2 million lives up until the end of last year. 7 million this year. So we'll improve 6 million lives across all of our programs this year. We can write about 50 essential medicines. So yeah, improve more lives, increase the number of medicines that we're distributing, making available. And then yeah, absolutely more countries to enable that really. So more bigger portfolio, improve more lives through the education, screening, access to doctors. The other numbers of countries. We're relatively large in India, pretty much nationwide. Our 300 full-time staff now. Yeah, we're committing to Asia for sure, but East, South, West Africa are where the health access needs. Medicine pricing is crazy. Africa, in rural communities in East Africa, medicines can be 30 times more expensive than in the UK. So what I can pay 50 cents for in the UK might cost me $15. It's sometimes $30. People do not realize what you can, like half a dollar for in India can cost $0.5 in India can cost $30. And when you go to pharmacies, we map price, it can cost $28, $30 in some places of East Africa. So yeah, we're thinking about Africa as a big growth region, surely based on the need and the market inefficiencies and the ability to make money and do good by disrupting a pretty broken sector that needs to be redeveloped fundamentally.
So could you share about a personal story about a time that you've been brave?
Many in a way, I try to repeat the complexities of the sector that I work in, rural, the amount of vested interests and the people that you upset in doing this. Often the big distributors won't work with us. If you're already selling a medicine that should cost $1 for $30 and you're the distributor, often the distributors make 3, 4, 5, 10, and the products they distribute, what interest does the distributor have to introduce a $1 product if the market is currently overpaying at 30? Political connections of those people, the risks of upsetting powerful local cronies, if you will, is hard. It's real. You can't really put yourself at personal risk, as to the team, through creating a bit of an imbalance in some of these sort of vested commercial interests. So I think that's probably quite key. And yeah, definitely as we get to scale, definitely as we look at new markets, you are upsetting a balance that has to be watched constantly. I'll rebel and I'll probably give another, quite a few examples, but yeah, that's definitely the one that comes to mind, to be honest.
What keeps you going? That sounds like a really tough situation to be in.
A lot of people would look at my job and it's definitely a tough job. I've chosen a very hard sector to build in. It's absolute grind of pressure and problems. It's like not an easy day. The hard dollar to earn, I always say. If I wanted to make money, there's easier dollars I could make than like, it's like a hard dollar well earned and reach 52. Honestly, I really hate the problem that I'm solving. It's absolutely, I don't think I'm allowed to swear on this podcast, so I won't. But if I could swear, it's effing offensive how much people pay for basic medicines. Well, we wake up in the morning, I'm like, walked in, I'm in the office, and I walked in this morning, paid $6 for a coffee. That to buy 3 packs of medicines that would save people's life. And for some reason, in Africa, rural Southeast Asia, that's too expensive. We can't afford the medicines. People don't have basic antibiotics, vaccines, and that. So what I spend on a coffee every morning could probably save 3 lives globally. But for some reason, that medicine's too expensive. It's not affordable. No one's willing to pay for it. If people are paying out of pocket, it's actually not a $2 medicine like it should be. It's a $20 medicine. It keeps me up at night, genuinely. And it still does. I try and put myself in the shoes. Imagine now you're in rural Philippines, rural Indonesia, family hurt, famine worrying, you're lying in bed at night, bit sweaty, some mosquitoes, whatever. And your mum has renal failure and you have cancer or whatever. You even just more basic stuff than that. You have a basic disease that is absolutely 100% treatable, and you know that you or your family member is going to die. And I try and put any probably taking a loan. One of the biggest causes of people going bankrupt is health expenses. People borrow money from loan sharks. Including in America, one of the biggest causes in America when people get bankrupt is health expenditure. Just imagine being in that person's shoes. And obviously, once you can't unsee it, we've had interns come to Reach 52 and so on. Once you see that problem and you really empathize with those people, you cannot unsee it. And yet, therefore, I'm happy to keep doing it for the rest of my life because I think it's the right thing to do. And I try and imagine those now 4.5 billion people, used to be 3.7 billion people that can't access healthcare. It is going up. Health expenditures being cut post-COVID. Population growth is going up in emerging markets with weak healthcare access. The problem we solve is actually getting bigger, not smaller. And yeah, I'm happy to create my life to try and solve it.
So when you think about going from point A to point B, which is from London School of Economics and undergraduate to where you are today, and you go from point B to point C, which is another kind of 8 years in the future, what are the things that you feel that you can't unsee versus things that you have to see differently or change?
That's big. That's a big question. I think, yeah, to some extent it's here. So if I take the earlier example, fast scale, be asset light, be resource light with the original hypothesis, I've now come to this conclusion over the years that I would say I went past wanting to get my hands dirty to getting my feet really wet. I had this phrase before, but now I've just got, I don't want to get mud on my face. I want to be like a filthy guy from a business point of view. I've gone from trying to be a tech guy to then getting my hands dirty. And now my feet are just dirty and wet. And I want to continue to embrace the complexity of the sector, which in turn, by embracing that complexity, having the distributors, having the regulatory teams to help register medicines, government affairs, getting government engaged, education, screening, training doctors, that's all complex stuff. But if we solve that, if we have a SAP call to solve that, then let's just say you're a pharma company now willing to give some affordable medicines. You're willing to lower the margins to your products. You work with us. Simple. Just sign a contract. All you have to do, we'll do the registrations, we'll engage the government, we'll get permissions, we'll train the health workers, we've got the distributors lined up already. All of a sudden, health rule can become a reality because the complexity we embrace takes away that complexity for people that frankly wouldn't, shouldn't, and probably couldn't build it themselves. Just too complex. You've only got one product. It's not worth it. Your boss won't give you the resources. You're not going to spend all your money in rural India if you can go after Dubai as a market or whatever, right? So yeah, I just want to continue to my hands dirty up. And by doing that, it will actually mean other partners in these sectors because we have that sort of holistic, comprehensive offering. Still tech enabled, still innovative, still asset light, resource light. We don't want to build a big multinational corporate, right? But yeah, just definitely going more down that path of building these different core teams, enable key actors to come in and make a difference when they probably couldn't without someone like us.
Yeah. On that note, when you look at all of it today,
Crazy thunderstorm in Singapore.
I
Not,
know.
not wind, not gunshot, but yeah,
Yeah,
if you lightning out, then
we're going to edit that one out. On that note, thank you so much for sharing about your journey. I like to summarize the 3 key takeaways. First of all, thanks so much for sharing about like the early chapter, Reach 52, in terms of some of the early formulations of how you see beneficiaries benefiting versus how the business model and approach has changed over time. Secondly, thanks for sharing about social enterprises and about whether it's in vogue or not in vogue, whether it's a business or a startup or health equity. But it was fun to discuss how people have shifted their opinions about what kind of business models are in favor or not versus how founders should just be focusing on what really benefits the people at the end of the day. And lastly, thanks for sharing about what keeps you going. I love what you shared about what you can't unsee what you've seen in terms of having the empathy and understanding of what a life-changing moment it is for a person to have medicine versus not to have the healthcare they need to have. On that note, thank you so much for sharing your experience.
thanks so much. Thanks for listening as well. And thank you very much for having me again. Yeah, have a great day, evening, morning ahead, wherever you are.